So what I wanted to do was just really put it a little bit in context, thinking about brain in terms of the whole cancer services, but also thinking about what we might measure in terms of thinking about how we know that we've made a change and how we know that that change is an improvement. So that when we're thinking about this afternoon in terms of shaping services and taking things forward, we think about it within that context. So I just, first wanted just to remind you of the complexity of cancer and how different it is now compared to how it used to be, and how difficult that is sometimes for people to engage with. So if you take the dotted line there, it shows how survival for cancer has improved since the 1970s. And in the top left-hand corner, you have a group of cancers where most people are going to live a decade. And from the brain tumour point of view, you're going to have cancers which are curable, where people are going to live their lives for many years afterwards. And then you have a different set of cancers, say for example here, where really nothing has happened in terms of overall survival for the last 20 years. And sadly, many brain cancers will fall into that category. Not all of them, as we've heard, but many brain cancers will fall into that category. And then we have a third group of cancers where increasingly you have a relapse and remit program where they still have active cancer, but there are many treatments that can be given to help. And those three trajectories are very different. So your top group of cancers, your priority is going to be rehabilitation, maintaining function, making sure that those people are restored to normal life. For your bottom group of cancers, you're going to be aiming for earlier diagnosis in order to prevent them being in this group, but also making sure that just because they're not going to have clever anti-cancer treatment, that they are still able to have support from specialist services. Because specialist services are not just the clever equipment, as we've heard, they are the things which will restore and help function. And then the third group, for example, the low-grade glioblastomas, the meningiomas, where people have difficult periods of time for months and years afterwards, there you've got a different trajectory. You're not dealing with the short-term function of people who are going to be dead within a year, nor are you dealing with the curative function, where people are going to have a normal lifespan. Now you have a much more chronic function. So that one needs to be thinking about brain cancers in terms of the sort of trajectories that they're going to have. And sort of looking at it, the majority of glioblastoma will fall into group 1, which falls into the really poor prognosis, whereas the majority of meningiomas will be living 7 years or more and may have all sorts of problems later, similarly with the nerve sheath tumours. So we've talked about thinking about the prevalence of the different sorts of cancers, the sorts of points where things go wrong, and the sorts of interventions that we might make. And I think we've been talking about some of the simple things that can be done to make those things better. And prevalence looks very different for different cancers. So just thinking perhaps a little bit about this neck of the woods, that brain and cancer incidence is similar to the rest of England, that the majority of brain cancers are high and low gliomas and meningiomas, that the low-grade gliomas are increasing, that most people are treated within Hull, and that the one-year survival rate is lower than the England average, and so there is a real emphasis on the importance of early diagnosis. So we do need to really think about that. We know there's an inequality of experience between different parts in here, that in Humber, that over cancer, there are problems related to patient experience, and everybody knows that that is the case, even though there's really excellent care. And that there's a particular problem, forgive the technology, but there's a particular problem in relation to information. But of course, within Humber, there are a lot more challenges. Life expectancy in general is lower, and I don't know that in general is lower, that there's much more deprivation. And and so these factors are the background in which you have to work. You have particular challenges in which to work, and it is unfair not to take those into account. I was very struck in one of our medical dinners of someone saying how, of course, in the Hull area, it's the lowest car use in the country. So the challenges of getting from one place to another are enormous here, and much more so than in other parts of the country. So in terms of thinking about what we need to do next, it's thinking about the particular challenges here, the particular strengths that you have, the background stuff, recognising that all of that is going to be important in thinking about how to redesign services. And recognising that that background is really important. So what are the things that we can do in terms of thinking about how to make the small changes that might make a difference? And I think one of the things is making invisible things visible. So hearing from the patients and the carers about their experience makes those invisible experiences visible, so that we take those into account when thinking about redesigning services. Thinking of the small things, the difficulties in communicating with each other, the difficulties in getting information from one place to another, the challenges in sharing expertise across teams. So some of those small things that we could really make a difference. So making the invisible visible is one of the most important things of this programme. Some of the quotes we've had from some of our recent bringing together of specialists and generalists. So I had an 80-year-old patient who could tick all the boxes in terms of professionals involved, but it was just a series of transactions with each person doing their own thing and not being joined up. Big problem is assessing cognitive function. Sometimes it's simple things. He's not demented, he's deaf, which came out as very strongly. Junior doctors saying we don't get enough training in assessing capacity. The junior doctors and junior staff within hospital are often ignored in terms of thinking about the importance that they have in some of these areas. There was one comment from the importance of the skills in geriatric medicine, where they pointed out that in elderly care we see all the patients, and that seems to be a novelty in some cancer MDTs, when you're lucky if one person has actually seen the patient. Now, I don't think that's going to be the case here, because clearly you're talking about very well integrated teams, but that was an interesting comment. Comment from an oncologist: no real efforts are made to contact the GP except through letters which are not read. And I thought this was sad. The last time I met a patient's GP was at the patient's funeral. Patients come back to us sometimes to say they wouldn't have had the treatment if they had known the effects on their lives. Comment from an oncologist: I don't always see the referral letter from the GP, which has the details about family. It may just go to the surgeon. So just quite small things that people have expressed about their experience of managing care, which I think in these sort of fora can come up and are things that we can do something about. Sometimes from the dinners where we bring people together, we identify a problem, and then we can do a very quick survey monkey across GPs to find out whether it's a problem that everybody has. So, for example, what came up in one of our dinners between radiologists and GPs was the issue about access to MRI. So we then did a quick survey monkey around GPs to find out whether they had access to MRI in their patch, and found that only 50% of GPs actually had direct access to it. So in this one, it's identifying a problem, doing a very quick survey to find out whether that's a general problem, and then being able to bring that to the attention of other people to show them this is something that you need to do something about. So that's an example of a local thing that it's very possible to do. They also showed that there was sometimes a month between actually ordering the test and getting the result. So it's not just about access to the test, it's making sure that you have a proper system in place to make sure that the results are conveyed. So that was a really important factor. And I think, really, finally, it's thinking about new ways of working. It was really inspiring to hear our neurosurgical colleagues talking about leading a team of leaders. So So it's not just the specialist services, but it's also how we move to sharing expertise between teams, across organisations, between generalists and specialists. And I hope that some of those small things will come out today. So remembering that relationships always outlast organisational structures and projects. And I think I'm just also one final thing, just to remember that we also have within Hull one of the specialist end-of-life care projects, which we can link into, which I think may be very important in providing some expertise in relation to that project. And I think we're hoping that that is going to link in. So what I would like to really think about is one of the things I suppose that I wanted to really emphasise was the importance of working at the boundaries, and how we can think about working at the boundaries, and how can Macmillan help to actually work as a bridge across it. So I'm going to stop there, and really, because many of the things that I would have said have already been said by others, and the most important thing is hearing what you've got to say in terms of taking things forward. And I was told to make sure that you all vote. Thank you very much.